Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
This program is presented by Medscape Education Global.
Hello, I'm Professor Nadja Harbeck. I'm the director of the Breast Center at LMU University Hospital in Munich, Germany. Welcome to this Medscape program, Latest Advances in Breast Cancer, Essential Highlights from San Antonio 2024, providing you a rapid data digest on recent data from this SABCS 2024 meeting. In this first chapter, I will discuss data updates on local regional breast cancer therapy. Actually, local regional breast cancer therapy was one of the highlights at the San Antonio meeting, and the middle day was filled just with local regional abstracts. One of the practice-changing studies is the INSEMA trial. INSEMA included about 5,500 patients and asked the question, if I have a clinically negative axilla, do I really need to do the sentinel? There was a second randomization looking at positive sentinels in axillary clearance versus sentinel alone. But the main objective was to see whether the IDFS after breast conservation is similar between no axillary surgery and the sentinel procedure. The study reached its primary endpoint, and the curves were almost identical, and the hazard ratio was entirely below the non-inferiority margin. Actually, invasive local regional recurrences were very low, with less than 2% in both arms. So the INSEMA investigators concluded that their concept is feasible and that this de-escalation concept is suitable for patients 50 years and older, G1, G2 tumors, HR-positive, HER2-negative subtype, and a preoperative tumor size of up to 2 centimeters. Second trial, Supremo trial, also practice impacting data, 10-year results from a trial that looked at intermediate risk early breast cancer, whether patients after a simple mastectomy and axillary staging really needed thoracic wall irradiation if they had node-negative disease with risk factors or 1 to 3 positive nodes. The investigator reported the 10-year outcome, and there is no difference between the two curves in the 10-year data. And so the investigator concluded that the adjuvant chest wall radiation should be omitted in most patients, meeting the eligibility criteria for the Supremo trial. And I think this data is particularly important for patients who opted for breast reconstruction, because we really don't want to irradiate implants if it's not really necessary for outcome. Another trial, the Europa trial, looked at the question whether in women 70 years or older with early stage luminal-like breast cancer, either radiotherapy or adjuvant endocrine therapy are sufficient. The primary endpoints are breast recurrence rate at 5 years and the quality of life at 2 years. And we saw this second primary endpoint, this interim analysis. And actually, the radiotherapy had the better quality of life at 24 months and the lower incidence of treatment-related adverse events. From an oncological point of view, there were no warning signs regarding stopping rules, which would have been an in-breast recurrence rate of 2% or higher per year, or 7% distant metastasis. In fact, there were no distant metastases so far after 2 years, and no deaths from breast cancer. So the investigators concluded that either radiotherapy or endocrine therapy are viable single modality options in these elderly patients with low risk luminal-like breast cancer. And I think actually that's radiotherapy, because it's a one-time procedure, and once it's over, can be over in 5 days or a little bit longer. Actually, patients are not burdened with any treatment anymore, and this may be a viable option for patients who are hesitant to have a endocrine therapy every day. The COMET study was a very interesting study looking at the question whether we can do active monitoring or surgery for low-risk DCIS, and the oncological data were accompanied by a second abstract looking at patient-reported outcomes. The study recruited about 1,000 patients, randomized 1-to-1 between guideline concordant care, which was breast surgery and radiotherapy if indicated, and active monitoring. The experimental arm required breast imaging every 6 months. If there was a change, another biopsy, and adjuvant endocrine therapy was actually permitted on both arms. And the primary outcome was invasive breast cancers detected at any time. And actually, the study showed that the 2-year cumulative rate of invasive breast cancer was 5.9% in women randomized to guideline concordant care versus 4.2% for active monitoring, and that 31% of the participants did not adhere to their arm allocation, and more patients actually favored the active monitoring. Again, with the potential impact of endocrine therapy in both arms. So active monitoring was actually also using a preventative therapy. And the patient-reported outcomes demonstrated that the overall quality of life and anxiety, depression, breast cancer worries, and symptoms trajectories were quite comparable between the two groups, and there was no evidence of a substantial negative impact of either modality over the first 2 years. Data is early. We still need to follow the patients longer, but I think this provides very important data for patient counseling in these low-risk DCIS cases. Going back to the neoadjuvant therapy, we had the Alliance trial that looked at the upstaging of axillary surgery in patients with positive sentinel procedures. Again, about 900 patients in each arm, and most of the patients had HR positive, HER2 negative disease. The additional rate of positive lymph node was 46%, so somewhat higher in this study after neoadjuvant therapy than in the other studies. And obviously, the number of additional positive lymph nodes was influenced by the burden of the disease. And so in total, axillary lymph node dissection led to an upstaging of 25% in nodal stage. And I think it's very important to see the outcome data from this trial in order to see whether this has any impact on our management. And in the same category, we had the large European Axana effort, which looked at axillary ultrasound to whether it's reliably able to determine nodal status after neoadjuvant chemotherapy in initially node-positive patients. And what the Axana trial actually shows that there was a high proportion of false negative, but also false positive results. And actually just doing axillary nodal dissection based on ultrasound after neoadjuvant therapy may result in surgical overtreatment in about 36% of the patients, and in particular in the high-risk subtypes. So I think all of these trials show us that we still have some work to do in how to approach the axilla after neoadjuvant chemotherapy. We also have to take into account that we need still some of the nodal information in order to make the right decisions for further therapies, like, for example, CDK4/6 inhibitors. And the last two trials I'm going to show you are two investigations that we can use to counsel patients. First of all, the Oxford Overview analysis showed us updated data in 210,000 patients on body mass index and obesity in breast cancer. And what the investigators found was that BMI is associated with distant recurrence risk. It's a high risk factor, and that is independent of the systemic treatment, independent of the ER/PR status, and independent of menopausal status, so though the impact is somewhat weaker in postmenopausal patients. I think this is something very important that we need in order to counsel our patients properly. And the last abstract was by Dr. Matteo Lambertini in a huge international effort with over 6,000 young patients with germline BRCA mutations. They've already published on pregnancy and fertility in this cohort, and now they looked at risk-reducing surgeries in those patients. And what they found was that both for risk-reducing mastectomy as well as risk-reducing salpingo-oophorectomy, there's a positive impact on improved overall survival and breast cancer-specific free survival. And for example, the impact of risk-reducing mastectomy is independent of the specific BRCA1 gene. So I think it's very important to discuss these data with our young patients so they can make an informed consent on how they want to proceed with their surgical options regarding risk reductions. And with that, I would like to thank you very much for your attention, and I now invite you to listen to the next chapters in this program.
Hi, I'm Kevin Kalinsky. I'm a professor at Winship Cancer Institute at Emory University in Atlanta, Georgia. And we're going to be discussing early breast cancer, where this will be the first of two parts. So the first abstract that we're going to be discussing are data that are looking at the impact of anthracyclines and high genomic risk node-negative hormone receptor positive HER2 negative breast cancer. And as some of the background, really the question has been from data that we've had of for patients with hormone receptor positive disease, who do we really need to utilize an anthracycline, given that we're giving endocrine therapy? Who really seems to be benefiting from anthracycline-based treatment? And so the authors looked at the TAILOR-X trial, which we know was a landmark game-changing study for patients with node-negative breast cancer that was ER positive, where patients who had high risk recurrence score per the 21 gene assay received chemotherapy followed by endocrine therapy. So these are patients who had a recurrence score of 26 to 100. All of these patients received chemotherapy followed by endocrine therapy. And so the authors went back and then looked at the patients who had a recurrence score that was less than 31 or a recurrence score that was greater than or equal to 31. And what they saw was that for the patients who had a recurrence score that was greater than or equal to 31, there's actually a notable magnitude of benefit when patients received anthracyclines. You can see the hazard ratio was 0.32, which was statistically significant. And they looked at other endpoints as well, like distant relapse-free survival, as well as overall survival. And they saw for distant relapse-free survival, again, that there was an improvement in this group if you had a recurrence score that was greater than or equal to 31 with giving an anthracycline. And then they broke this out by tumor size and they looked at different variables. And what was notable was that those patients who had a tumor that was greater than 2 centimeters, these were also the patients who seemed to benefit. Like those T1 tumors did not seem to benefit with the same magnitude of benefit. The other thing that's worth noting is they broke this out by pre and postmenopausal status, and the hazard ratio was about the same. And they also looked to see, okay, like when did the timeline, for that recurrence score, what was the magnitude of benefit? And it did seem to be incremental, meaning really you started to see the benefit with that recurrence score that was greater than 30. And as you continued that continuous level, you saw that the hazard ratio only got increasingly better, but also recognizing that, fewer patients, for instance, had a recurrence score, say, of 50. And so the take home from this abstract was that there was this improvement for patients who have hormone receptor positive HER2 negative breast cancer that was lymph node negative, that had a recurrence score greater than or equal to 31. And these are the patients that you might think about giving an anthracycline, but also understanding that there are limitations to this analysis. The study wasn't designed to specifically answer this question, though it does suggest that for those patients, we might at least have the conversation about anthracyclines, but also understanding this before we had the initiation of CDK4/6 inhibitors as well. So moving on to data from the WSG ADAPT hormone receptor positive HER2 negative study. These are data, the study's been described before. We're essentially, I know this can be various cohorts that are being described, albeit to say that those patients who had up to 3 lymph nodes involved, if they had a recurrence score that was 12 to 25, and they did not have a response to their endocrine therapy, pre-surgical endocrine therapy, they received chemotherapy, and it also included patients who had that same, up to 3 nodes involved, who had a high recurrence score, meaning greater than 25, or if patients happen to have 4 or more lymph nodes involved, these patients received chemotherapy. And what this study report at San Antonio was looking at were those patients who were pre-selected by their recurrence score and endocrine therapy response. And ultimately, you can see across the study, when we look at endpoints like invasive disease-free survival and distant free survival and other endpoints as well, that there didn't seem to be a difference. But what was of interest is if you're looking at the patients who did or did not have an endocrine therapy response, did they benefit from getting nab-paclitaxel versus paclitaxel? And this is what the curves are really showing, is those patients with 1 to 3 nodes involved, if they had a recurrence score that was less than or equal to 12 and they had an endocrine therapy response, but in particular, those patients who got chemotherapy because they had a recurrence score that was less than or equal to 25 but did not have an endocrine therapy response, those patients in particular seem to benefit from getting nab-paclitaxel. But the downside is that there can be more associated toxicities that we can see with nab-paclitaxel, and there were more grade 3 or higher events. And so the take home from the ADAPT study is that it did confirm that response to pre-surgical endocrine therapy, we're looking at change in Ki-67, did seem to discriminate. Okay, these patients seem to do well. But for those patients who did not have that sort of response, really the question was, all right, well, should we be thinking about giving nab-paclitaxel to these patients compared to paclitaxel, understanding that we're still awaiting the results of other studies like the ADAPT cycle trial, which is actually looking to see whether patients need chemotherapy at all in subgroups, or can they get the same sort of benefit with CDK4/6 inhibitors. And so to contextualize those data, in the US, we don't as much give pre-surgical endocrine-based therapy, where we look to see that as a measure of endocrine therapy response, though these additional follow-up do suggest that that's really a viable way for us to really look at endocrine responsiveness. And it might, for those patients who don't seem to have a response, speak to the fact that these patients might have a benefit with nab-paclitaxel, though understanding that the field is changing and asking the question, is it really worth the risk that's associated, including the increased risk for grade 3 or higher neuropathy? And then lastly, Geparduozo. This was a study that was looking in patients with triple negative breast cancer, where essentially patients are getting Taxol, carboplatin, followed by anthracycline, with or without atezolizumab, understanding that we give pembrolizumab in this setting. The question really is, does atezolizumab benefit patients in the same sort of context? And so they looked at event-free survival, including secondary endpoints as well. And then ultimately, the hazard ratio was 0.8, but there was not a statistically significant difference when looking at those who received atezo or not. And then looking at overall survival, there was not a difference. And we know the immune-related adverse events that we can see with IO. And so ultimately, we did not see an improvement in event-free survival. It did show an improvement of PCR, and there were no unexpected toxicities. But at the end of the day, we already have the approval of pembrolizumab, and I would say that the field has not changed, that for our patients with triple-negative breast cancer, we would still be utilizing the Keynote 522 regimen for these patients, though this was an eagerly anticipated trial to see whether or not we would see that sort of benefit with atezolizumab. Thank you for your attention, and I would invite you to look at the other chapters, which will be further breaking down the data that we saw at San Antonio.
My name is Sarah Tellini, and I'm a breast medical oncologist at Dana-Farber Cancer Institute. And welcome to this next chapter entitled Early Breast Cancer, Precision Therapies and Biomarkers. This year at San Antonio, we saw data from the ZEST trial, which was a randomized phase 3 study that was originally looking to compare niraparib to placebo in patients with detectable ctDNA. And so what we saw from this trial was prevalence of detection of ctDNA in a population of patients who had early stage breast cancer and had completed their either preoperative therapy or adjuvant therapy, and then had blood drawn to see if their ctDNA was detectable. This trial enrolled 1,900 patients and checked their ctDNA and found that of those 1,901 patients, 147 patients had detectable ctDNA. So 8% of the population was ctDNA detectable. And at that time, when their ctDNA was detected at study entry, half of the patients who had detectable ctDNA actually had evidence of metastatic disease on staging scans. When looking at the patient population that was enrolled in this trial, you can see that it actually was quite a broad array of patients. In fact, about 25% of these patients had stage 1 disease, 40% stage 2, and about 30% stage 3. And it was a mixture of patients who had experienced a pathologic complete response, as well as patients with residual disease, with about 2/3 of patients having residual disease. When you look at the association of ctDNA detection with patient characteristics, you can see that it is more common to have detectable ctDNA if you had higher stage disease or you had residual disease as opposed to having experienced a pathologic complete response. And so in this trial, they unfortunately were not able to move on to the randomized phase 3 study to complete it. They only had a small proportion of patients that actually enrolled into this trial, but it was felt just not to be feasible because such a high prevalence of detection of gross metastatic disease was found when patients had detectable ctDNA, and therefore those patients would not have been eligible to the intervention. But I think this study did teach us a lot, which really was that we are seeing that about 50% of patients who have detectable ctDNA, unfortunately, have metastatic disease at the time of detection. And most ctDNA was detected within 6 months of the end of study treatment. And so this does leave us with a big question about whether or not we can really intervene in patients who have detectable ctDNA in the early stage setting and change the course of outcomes. It looks like with this current study and assay that doesn't seem to be very likely. But if we had a more sensitive assay, could that have been possible where we maybe were picking up the ctDNA at an earlier time point before metastatic disease had actually taken over? So again, I think a lot of questions here, but clearly very important data that we saw in the ZEST study. Another interesting trial that we heard at San Antonio this year was an updated analysis from the Olympia trial. This was a phase 3 study of adjuvant olaparib in patients who had germline BRCA mutations. We'd already seen the data from this trial where we had seen that using 1 year of adjuvant olaparib did improve both invasive disease-free survival as well as overall survival. Now, however, we are seeing longer follow-up data from this trial. So what we've seen now is the updated invasive disease-free survival data suggesting that at 6 years, there's a 9.4% difference between the two arms, consistent with a hazard ratio of 0.65. And this invasive disease-free survival benefit is really seen irrespective of hormone receptor status, so that you can see in patients who had triple negative breast cancer, the hazard ratio was 0.65, and in patients who had hormone receptor positive breast cancer, the hazard ratio was 0.68. We also saw updated data for overall survival, and at 6 years, there was a 4.4% difference between the two arms, consistent with a hazard ratio of 0.72. So really, this updated analysis from Olympia has shown us that these benefits in terms of invasive disease-free survival and overall survival are very robust with a year of adjuvant olaparib. We also saw that with longer follow-up, there are no new safety signals. So in fact, there is no difference in rates of myelodysplastic syndrome or AML between the two arms, which I think is really important because that was initially a significant concern with use of PARP inhibition in this early stage setting. So I think really nice to see this longer follow-up data. We also saw some data from the Keynote 522 trial. As everyone knows, this study really did establish the use of pembrolizumab as standard of care in patients getting preoperative therapy with chemotherapy and checkpoint inhibition. The question, however, that we have had is, are there particular patients who derive more benefit from pembrolizumab than others? And are there some patients who, in fact, won't derive any benefit from checkpoint inhibition? So we've been looking to see if we could find biomarkers that could potentially help us with this understanding. And so at San Antonio this year, we did see an exploratory biomarker analysis from this trial where lots of different analyses were conducted, including looking at T-cell inflamed gene expression signatures, tumor mutation burden, and more. And so I think while these data were very interesting, it was hard to find a truly predictive biomarker for pembro benefit. And again, some suggestion maybe that TMB could help, that having a T-cell inflamed signature was positively associated, but nothing in my mind that was sort of actionable that we would be able to take on now to help us select patients for who should get pembrolizumab and who should not. We also saw subgroup analyses presented from Keynote 522 looking at overall survival by various subgroups, including by stage, so stage 2 versus stage 3, where we saw similar benefits in terms of overall survival in both stage 2 and 3 patients and in patients with T2 and 0 tumors. And so I think this, in my mind, really suggested that there wasn't a particular subgroup that was not deriving benefit in terms of overall survival from the use of pembrolizumab. I don't think we can say that there's a particular stage or clinical anatomic feature that would help us understand if someone did or did not need pembrolizumab in the early stage setting. We also saw some data from the Solti-Valentine trial. I think this was a really intriguing trial because it was looking to understand the benefits of using patritumab deruxtecan or HER3-DXd in a preoperative setting in patients who have ER-positive disease. So this trial took patients with ER-positive breast cancers that either had a high Ki-67 defined as being greater than or equal to 20% or having a high genomic assay score, and they had to have a tumor that was greater than or equal to 1 centimeter, and they were randomized to get HER3-DXd alone, HER3-DXd plus letrozole, or standard anthracycline taxane multi-agent chemotherapy in the preoperative setting. And the primary endpoint was looking at pathologic complete response rates. What we saw was that the PCR rates in all 3 arms was actually about the same. So you could see the PCR rate for HER3-DXd alone was 4%, for HER3-DXd plus letrozole was 2.1%, and for chemotherapy was 4.2%. Interestingly, when you look at the imaging response, you can see very high rates of objective response in all 3 arms, really ranging from 70 to 80%. This to me does suggest that one drug, HER3-DXd, does seem to be performing just as well as multi-agent chemotherapy in this setting. However, I will say that I was a little disappointed with the rate of PCR in this population being so low. My guess is it's due to the patients that were enrolled, with a lot of these patients actually having luminal A cancers and probably not the most chemosensitive cancers. So, I think I would love to see how this would perform in patients who had very high genomic assay scores to see if we're really in line with chemotherapy in a population that is really deriving significant benefits from chemo. But again, certainly shows that this drug is very active and performing just like chemo, even when just one ADC alone. So, hopefully we will see more to come from this particular agent. I'll now invite you to listen to the next chapter that will focus on metastatic breast cancer updates from San Antonio. Thank you. Hi, welcome to this final chapter, Updates in Metastatic Breast Cancer from San Antonio Breast Cancer Symposium. The first of these is the EMBER-3 trial. This was a randomized phase 3 study with 3 different arms. This trial enrolled patients who had metastatic ER-positive breast cancer who had either recurred on or within a year of their adjuvant AI or had progressed on first-line therapy with an AI with or without CDK4/6 inhibition. These patients were then randomized 1:1:1 to either receive imlunestrant alone, so the oral SERD by itself, or standard of care endocrine therapy with the choice of either fulvestrant or exemestane. And in fact, in this arm, 90% of patients, in fact, got fulvestrant, or a third arm, which was a combination of imlunestrant and abemaciclib. And so the trial was really trying to address a few different questions in one study. And so what we saw was, with regards to the first question of comparing imlunestrant to standard of care endocrine therapy, we saw that imlunestrant was better than standard of care endocrine therapy in patients who have an ESR1 mutation, where the PFS for imlunestrant was 5.5 months compared to 3.8 months in the control arm. However, when you look at the ITT population, there was no difference between the two arms. With regards to the question about the combination of imlunestrant and abemaciclib and how that compares to imlunestrant alone, we did see that the combination, in fact, was superior to imlunestrant monotherapy, with imlunestrant abema being associated with a 9.4-month PFS compared to 5.5 months for imlunestrant alone, consistent with a hazard ratio of 0.57. And the benefit for the combination was seen both in patients with ESR1 mutations as well as those without. So really suggesting that this benefit is seen irrespective of ESR1 mutation status. In this trial, about 60% of patients had seen a prior CDK4/6 inhibitor, and we saw that the benefits were seen both in those patients who had prior CDK4/6 as well as those who had not. We've also saw that the benefit was seen irrespective of PI3K pathway alteration. So I think what we've learned is imlunestrant's better than standard of care endocrine therapy in ESR1 mutant patients, and that the combination of imlunestrant and abema is better than imlunestrant irrespective of biomarker. We also learned that the combination as well as the monotherapy were generally very well tolerated, with about 4% of patients discontinuing imlunestrant monotherapy in the trial due to toxicity, and about 6% of patients discontinuing the combination due to toxicity. So, in my mind, this does suggest that imlunestrant hopefully will become a new standard of care option as monotherapy in those patients with an ESR1 mutation. So another choice of oral SERD in addition to what we have currently, which is elacestrant. But I think what we're probably most excited about is the combination, because we currently do not have approval for a combination of an oral SERD with a targeted drug. The other practice-changing study that was presented at San Antonio was the PATINA trial. This was a very late addition to the program because the investigators had just received the data a week prior to the meeting and did come back strikingly positive. So this trial was a trial that was looking at patients who were getting treatment for the first line treatment of metastatic HER2-positive, ER-positive breast cancer. And the trial patients got induction therapy with chemotherapy and dual HER2-directed treatment, and after 6 to 8 cycles, were randomized to get HP maintenance therapy with endocrine treatment or HP maintenance, endocrine therapy, and palbociclib. So looking to add the CDK4/6 inhibitor onto the dual HER2-directed therapy with endocrine therapy as maintenance in patients who had disease control after being on induction for 6 to 8 cycles. And here, what we saw in my mind was very striking. The PFS in the control arm was 29 months compared to 44.3 months in those patients getting HP plus endocrine therapy plus palbociclib, consistent with a hazard ratio of 0.74. We also saw overall survival data, which was consistent with the benefit from the addition of palbociclib, with a hazard ratio of 0.86, again showing a nice trend towards improvement in overall survival. We certainly are familiar with the toxicities of palbociclib, and overall this looked to be a very well-tolerated regimen. And so this to me was very impressive, because we have never seen a progression-free survival of 44 months in a first-line HER2-positive population, and so really is shifting the trajectory of this disease. And so in my mind, I do hope that this leads to an official approval for palbociclib in this maintenance setting. Another important trial that was presented at San Antonio this year was the PADMA trial. This trial looked to compare first-line endocrine therapy plus palbociclib to chemotherapy in metastatic hormone receptor-positive breast cancer patients, where they were felt to be candidates for chemotherapy in this upfront setting. I think this is often a question that we have, is when we see a patient who presents with metastatic hormone receptor positive disease with significant amounts of for example, visceral metastases, where we feel that chemotherapy may be a reasonable choice, how does it compare to endocrine therapy and CDK4/6 inhibition? We've seen prior data with regards to this question from the Right Choice trial. This trial is a somewhat similar design because it's taking patients who you'd think about chemotherapy for, but in this case using endocrine therapy and palbociclib and comparing it to just one chemo drug, not doublet chemotherapy. So here what we saw was actually similar to what we've learned before, was that endocrine therapy and palbociclib does perform better than chemotherapy with a median time to treatment failure of 17.2 months for endocrine therapy and palbociclib compared to 6.1 months with chemotherapy. I think dramatic differences consistent with a hazard ratio of 0.46. So, in my mind, this really does suggest that for patients in this first line setting, for the vast majority of people, endocrine therapy and CDK4/6 inhibition is a very reasonable choice, even in patients with extensive visceral metastases. Another trial that we saw at San Antonio was an updated analysis from the DESTINY-Breast06 trial. This trial took patients in the first line chemo setting for metastatic ER-positive disease and then went on to this trial of either TDXD or chemotherapy. And we've already seen the data from this trial suggesting that TDXD did do better than chemotherapy in terms of progression-free survival, with a 5-month difference between the two arms. I think what we struggle with is trying to understand which particular patients are going to derive the biggest benefit in this upfront setting. And what this analysis showed was they looked at PFS based on time to progression on first-line endocrine therapy and CDK4/6 inhibition. So they, for example, looked at patients who had rapid progression within just 6 months of endocrine therapy and CDK, or patients who got 6 to 12 months on their first line, or patients with greater than 12 months on first-line therapy. And we saw that the hazard ratio for benefit was really, very impressive across all these subgroups. If you look at those patients with very rapid progression on first-line AI-CDK, you see the hazard ratio was 0.38. So that was consistent with a 7.5-month difference between the two arms. When you compare that to someone who was on treatment for longer, so let's say on AI-CDK for greater than 12 months, you see that the delta becomes a little smaller between the two arms. It's 4.7 months, and the hazard ratio was 0.67. So it does seem like those people who really rapidly progress through endocrine therapy and CDK, they're getting a very large benefit compared to standard chemo from use of TDXD. And so it does seem like a drug to use in those very rapid progressors. They also showed us data looking at progression free survival beyond TDXD, so looking at PFS2, so from start of study entry to time of progression after the next line of therapy. And what we also saw was that PFS2 was also better in those patients getting TDXD compared to standard chemotherapy, with PFS2 being 20.3 months in the TDXD arm, compared to around 17 months in the control arm. So certainly doing better all around across all subgroups, really solidifying the fact that TDXD is a standard of care treatment option for patients who have HER2 low or ultra low disease getting chemotherapy-based treatment in this first line setting. So another wonderful San Antonio Breast Cancer Conference with lots of data that really is going to change outcomes for our patients. Thank you so much.
This program was presented by Medscape Education Global.